Hi, hello everyone. Thank you for joining these NeuroTalks for today. We are just waiting for our guest to arrive. Here he is. Adding him to our meeting. Hi, hello Pedro. How
Hello,
are you?
Tiago. All
Hi.
good, thank you. How about you?
Thank you so much for joining us this afternoon for these NeuroTalks.
My pleasure.
Thank you. So just let me introduce you to our audience. Pedro is a very good friend and also is a consultant neurosurgeon at the National Hospital for Neurology and Neurosurgery at Queen Square in London. So thank you so much. It's an honor to have you here
My
and
honor to be here.
to talk about a subject that is definitely uh, not just an interventional neuroradiology subject. It's very broad, and neurosurgery has definitely something to do here, I think. And you agree?
Absolutely, absolutely agree.
Yeah,
Um,
so when we talk about AVM patients, definitely we need to talk about patients that have ruptured and those that haven't ruptured yet. So regarding the management of these patients, how do you do and what are the advices that you can share with our audience about how to manage patients with ruptured and unruptured AVMs?
well, I think if you allow me, just starting from the beginning, you just touched a very important point, which is, an AVM patient is not mine, is not yours, is ours. So,
It is.
yeah. So I think the best strategy will always result from multidisciplinary discussion and an open and unbiased, as much as we can, discussion, and we should make a decision together and together with the patient. Now, addressing
Yes.
specifically your question about ruptured and unruptured, I think they are two completely different entities in a way, because they do. I think it's fairly straightforward in terms of decision making for ruptured AVMs in
Yeah.
terms of the need for treatment. The unruptured AVMs is a completely different story, as everyone, I'm pretty sure everyone agrees. So they are very complex malformations that, or at least some of them are very complex, and they are, despite being histologically benign lesions, they do not behave as a benign lesion. So when they do bleed, the consequences can frequently be devastating,
Yeah.
and it afflicts a proportion of the population that is fairly young. So which is
Hmm.
something that has to be taken into consideration. So
Yeah.
I think, sorry.
No, I was going to ask if, for unruptured and AVMs, that I think is the most difficult point probably when you are offering treatment for a patient that probably is completely intact. It has absolutely no symptoms and probably did a CT head just for headache or something like that. That was probably not related to the malformation that he's carrying for ages. So how do you do that? How do you manage these patients?
Well, I think it's really the main aspects are exactly those that you mentioned. So they are generally young patients, well, asymptomatic. It was just an incidental finding. So I think the first thing to do is have an open discussion, see the patient, discuss to understand what their concerns are, and also what their expectations are. So it's important to have realistic expectations and to understand exactly what we're discussing. So what I generally do, I just bring them to clinic and I have frank and open discussion about the risks, what the patient has, what implications are. Um, it's important to understand how much that affects their psychology as well.
Hmm.
So I think some patients, are fine with it. They just say, "Well, I've had it for a long time. If it bleeds, and I'll take it from there." Some others will say, "Well, there's no way. I want to have this in my head. So if there's something that you can do, let's go ahead and do it.
Okay.
Sorry.
But from a morphological perspective, in terms of regarding the AVM itself, um, are there specific questions that you want to be answered by the DSA or CTA or something that will help you to decide if the patient wants to be treated? That will help you to decide in terms of this patient being in a higher risk for rupture, and so I would advise this patient to be treated.
Absolutely. So I think the first decision to make is whether the patient would consider treatment or not. If they don't, well, so obviously we'd just leave it for conservative management. If they do, the next stage will be to have a formal catheter angiogram, so digital subtraction angiogram, that will allow us to have a better understanding of the morphology, and if there are high risk features, as you mentioned, like flow aneurysms, intranidal aneurysms, venous pouches, a single draining vein, etc., etc. So, so it's really important so that you can estimate the risk of bleeding, or at least try to approach more accurate number, and also to give an estimate as to the risk of treatment. So
yeah. I can't just retain this question. What do you think about Aruba?
Well, Aruba, I think it was probably a honest attempt to shed some light on the soul. But I think it was flawed.
But because one of the questions that I put myself several times is that in the light of Aruba, sometimes it's difficult to propose to a patient that we can treat them with significant risk for the therapeutic option as well. But I understand what you are saying, that probably the risks that are mentioned in Aruba are probably higher than we can actually provide or offer to the patient, especially if we do if we offer a multidisciplinary approach, and we need to include here radiosurgery as well.
Absolutely, I totally.
Yeah, regarding rupture aneurysms, I have a question for you, because we know that these typical cortical lobar hematomas are obviously they will need DSA, but I know that you have a different experience. Well, not a different experience, but you have a different approach to every single intracranial, intraparenchymal hematoma. So, what's your management in London, in Queen Square, and also, of course, your own management of these patients?
Yeah, so I think that's a very pertinent question, because we do frequently assume, given the location, the comorbidities, the clinical history, that certain hematoma is hypertensive. And quite often we have a surprise, and we do find an underlying malformation. So I think it's really important to do regularly at least a CV angiogram. That it will, as I said, it will declare many malformations, and AVMs included, that would not be picked up if we didn't suspect. So we only prepared, unless it's something really blatant, we only prepared to recognize what we are looking for.
Yeah, of course.
So
and especially those ones that, yeah, go ahead.
No, sorry, I interrupted you. Go ahead.
No, I was just asking that probably those more difficult ones, well, more difficult because they are very deep, and the feeders are very difficult from an endovascular perspective. Those lenticulostriate AVMs that are very difficult to treat from an endovascular perspective, and I guess from your perspective as well. And they can very, very much mimic hematoma, hypertensive hematoma.
Yes, indeed. And I could, you mentioned lenticular striate AVMs, and it's a classical example. I do have, I don't know if I do have a case that I can show you, or if there's any interest in it.
Yeah, of course, yeah.
I'll prepare after this then.
Okay.
Sorry, I just lost my train of thought.
Yeah, those ones that are in the deep basal ganglia can be difficult
Yes.
to recognize.
They
Yeah.
can be difficult to treat surgically, and those are potentially amenable for radiosurgery,
Yeah.
and also sometimes for embolization. So you can do your magic
Yeah.
sometimes and do it.
Yeah,
And
we use that catheter actually. It's a private endovascular joke.
Yeah.
It's a magic catheter. Okay, Pedro, regarding treatment, and because we work together, what you are expecting from endovascular perspective? What do you need from us when you are when we think of an AVM that is being treated by endovascular and surgical means?
So I think it's really important to make a plan as to how you're going to treat the AVM. If it's going to be, surgery only, or if it's going to be preceded by preoperative embolization, or if you're going to embolize it fully. And I think that's really important to decide. So when you ask me about how do I manage patients if I see them in clinics, so I plan a DSA if they consider treatment, and then that DSA is purely diagnostic. So because I think we need to take a step back, and discuss, with time and unbiased, so that we find the best treatment options. So the embolization, if you aim, obviously different surgeons will have potentially different preferences. I think for me it's quite obvious that if you are aiming for preoperative embolization, my main focus would be in the feeding arteries. So that's what I would prefer if you could occlude at least some of them, because it will make the operation much easier and much quicker, and therefore much safer. I don't particularly see any advantage of trying to embolize the nidus fully, or a big portion, because then it will render the AVM very, very hard, and so it'll be very difficult. You need to you're dealing with a golf ball, and you need to look around to try to find minuscule vessels that are partially supplying the AVM, and then it may be much more difficult. And there are attachments, obviously, from the remaining vessels, so it's very difficult. So if the aim is to cure the malformation, the AVM and the vasculae, that's fine. That's the aim, obviously, of nidal embolization. If it's just for preoperative purposes, then I would rather not have the nidus fully embolized.
Regarding the cast, of course we can use glue. We can use several different other liquids that are non-adhesive, like onyx and Fill and others. For your approach and for your technique, I know that there are differences for you, and what do you prefer?
I personally don't have any clear preference. I would say that Fill is quite good in that it's white, so it's very easily recognizable intraoperatively. Other than that, I don't have any particular preference. There's probably one precaution that we have to take with when you do it with onyx, particularly if you are embolizing also branches from the external carotid artery, which is using the monopolar, which I don't actually do that often, so it won't be a problem. But it could be a problem for some operations because technically it could explode.
Okay.
Sorry, go ahead.
No, I think you have a case with Phil that you can
Yes,
show.
I do. I
Because
could just.
just let me explain. Pedro was just showing me the case before, and it was my first time seeing Phil in the brain. So I was very excited with that. So I think you can share with everyone.
There's well, sort of a joke that I tend to say to my neuroradiology friends, which is, you know the roads, we know. Sorry, you know the maps, we know the roads. So,
Okay.
so this is the road. I'm going to show you the road now.
The road. Okay.
So this is. I'll just. Sorry. Yeah. Okay. So this is a large grade 3 AVM that was previously embolized. So he presented with the refractory epilepsy. I don't know if you have a clear. Is it clearer now?
Well, yeah, as far as Instagram allows.
Okay, so what I'm doing here is just dissecting superficially. It's important to understand the architecture just all around. So it takes a while. There's, for some reason that I don't know, there's always thickening. There you see the fill. Can you see there? White?
Yeah.
Just about where I'm cutting.
Yeah.
So that actually already. So this has expanded and somehow ripped the vessel. So you can see that it's actually intracisternal.
Okay.
So, but again, you just work around, just find your way just before you dive in, because you do really need to know your limits, and particularly in this area that can be potentially disastrous. So I'm going to speed up because it can be a bit boring. That's Phil, okay, very clearly.
Mm-hmm. Mm-hmm.
And what it helps us is it will help to, if we do see that the blood vessel is embolized, then we don't need to inspect any further. We don't need to go any further proximal, so we know that that's where we need to stop. So it makes things much easier for us. It's not so much about the blood flow reduction, to be honest. And this is important. I just brought this. I don't know if you can see here. So this is the AVM, and this is actually an en passant vessel. You see there?
Mm-hmm. Yeah.
So this is actually supplying cortex here. So if you just cut, inadvertently, then you can be causing a stroke. It's interesting. This is not something that happens often, but I had to cut this AVM in two to be able to preserve this vessel.
Okay.
Obviously, after it had been disconnected. So I'm just going to fast forward a bit. And then I think in the end there's a good... You can see now the AVM split in two.
Yeah.
And then eventually this is the final result. And you can see something that we use to help us intraoperatively, which is ICG, so indocyanine green, sorry, which essentially is a dye that it's injected in the peripheral vein, and then when stimulated with infrared, you can see clearly, see the vessel? There's a bit of, and this is filling. If had I not been cautious enough, I would probably have taken the blood vessel and caused that.
So why does it help you? Sorry, I'm a neuroradiologist, so I assume.
Well, no. That's a very pertinent question. It helps in different ways. So it helps to see the normal anatomy. Sometimes it helps you to see which ones are veins, which ones are arteries, which not always is very clear, and it does help you to confirm that you've taken the AVM away. So if you don't see any early filling when you do the final run after you've removed the AVM, then you should be fine. But if you do see some early filling, then you left something behind, which is rare, but it may happen.
Yeah.
So I had prepared, I don't know if you, just to show the basics of AVM surgery. This is a small one.
Yeah, of course. Yes, of course.
Yeah. Okay.
Yeah, we still have time.
Okay. So that's a superficial AVM, same location, so Sylvian fissure, and we just start by dissecting the arachnoid. One thing that I don't use is retractors in general. So I ordinarily just rely on an assistant to help with do some dynamic retraction. So you can see there's one of the feeding arteries in the Sylvian fissure, and there are tiny little blood vessels supplying the AVM. Okay, so it's a game of patience, and you just buzz it bipolar and cut and go all around. And it's also it's always very important to make sure that all the unpassant vessels are preserved. Then you can see, so this is where the AVM, the limit of the AVM is. Some of the blood vessels, they will bury into the white matter. So we have to do a gentle dissection. Try not to go too deep. So it's just the glial plane. And you take the arteries, but not the veins. This is a very basic principle, because if you take the veins before you've taken all the arterial branches, then it will just swell up and potentially burst. Okay, so these are the two draining veins. I just apply the clip just for precaution, and then so there's one vein done, and then the other vein there. And cut and remove the AVM. So that's how it looks like at the end. So you can see now, it's very clear now, arteries and veins. You can see the color is completely different. So now that it's disconnected, veins look like veins, so they don't look rosy.
Yes, yes.
Okay.
Wow. Good job there.
Thank you.
Well, I think there's a question here from Carla Reizinho, that is a neurosurgeon.
Hi, Carla.
Well, actually, she was actually commenting on what you were saying. There is okay. So yes, Carla is asking if you do any preoperative MRI before surgery.
I tend to do, particularly if they are in eloquent areas, or and sometimes I couple that with tractography. It does help for example, for parietal or temporoparietal AVMs when you are concerned about the Myers loop. I've done on a number of occasions for callosal when it's not very clear whether this connection is complete. But it's not mandatory, but I think it does help in some circumstances. Helpful, or they may not seem helpful for you, but they are helpful for us to understand a little bit better the anatomy.
Yeah.
So it's helpful that we are there as well to, at the moment that the diagnostic angiogram is being done.
Okay. Probably taking care of the same patient. So thank you so much. And for the audience, thank you for being with us. And I see you probably next week. Thank you so much. Bye bye.
Thank you. Pleasure. Take care. Bye bye.